So I have to speak about the National Viral Hepatitis Control Program. You must have heard and learned about so many national programs which include tuberculosis, leprosy, many more. So this is one of such national program. We call it the National Viral Hepatitis Control Program. And we have not only to control the program, but eliminate the viral hepatitis. And my previous speaker has told you about the burden of the viral hepatitis and causing the morbidity as well as the mortality. As far as the origin of National Viral Hepatitis Control Program is concerned, I think its origin starts from the state of the Punjab, when in 2016 June, this standard operating procedure was laid down to control the viral hepatitis menace in the Punjab, particularly the hepatitis C virus. I told you in my introduction already that there are around 8 lakh people who are suffering from the active viral hepatitis C. Active means viremic, requiring the treatment in the state of the Punjab. And they have shown the good results in the Punjab, and the standard operating procedure were adopted by the central government, and the National Viral Hepatitis Control Program was started on this day, that is the 28th of July 2018. 4 5 years have gone by then, and I'll talk to you viral hepatitis control program. What is our global commitment? India is committed to progressively move towards elimination of viral hepatitis B and C and control of other viruses like hepatitis A and E. And we have committed it. We are signatory to it. This is in line with our global commitment towards the achieving SDG goal 3 and the target 3.3, which aims to end the epidemics of the AIDS, tuberculosis, malaria, and neglected tropical diseases, and now combat viral hepatitis, waterborne diseases, and other communicable diseases. So, what are the aims? What are aims? There are the 3 aims. 1, combat hepatitis and achieve countrywide elimination of hepatitis C by 2030. Achieve significant reduction in infected population, morbidity and mortality associated B and C. B and C, they are notorious for causing the chronic disease, cirrhosis of liver and its complications, and that can cause the morbidity as well as the mortality. And to reduce the risk, morbidity and the mortality because of the hepatitis A and E, that is something you cannot eradicate in near future, at least control them by providing the safe water. To achieve these aims, there are several objectives, at least there are 6. One is the enhanced community awareness of hepatitis and lay stress on the preventive measures. What we are doing today is basically is a kind of the awareness program as well. That you must know what is hepatitis A and E, what is the importance of drinking the safe water also, and what is the importance that we should not go outside in unauthorized situation and getting the injection just for the pain and the fever also, because they can cause hepatitis B, C, and HIV also. So this is kind of the awareness. That is the first objective. Provide early diagnosis and management of the viral hepatitis at all levels of the healthcare. You all know, if you don't diagnose an viral hepatitis B and C, they can go into the chronic phase and ultimately develop the complication and die also. So we should not go to that stage. So we have to have the measures to diagnose early and treat them. Third is the developed standard diagnostic and the treatment protocols. That is very, very important. Diagnosis doesn't mean that I have to move 10 kilometers or have to go to the other district or the town. There should be the point of the care test, means the diagnostic test should be available at the point where the individual or the patient is there, and at the same time once diagnosed they must be linked, there should be the linkage to the treatment, and that should be done at the All levels means district level, sub-district hospitals, and even the primary care centers also. Strengthen the existing infrastructure facilities. If all hepatitis, for example, B and C, they are being treated at the tertiary care center or the medical colleges, then hardly you will treat many patients or the many individuals. But if you think that if we train the primary care providers at the district level or sub-district level and they start treating, then you can see that the larger number of the patients could be diagnosed and the treatment. That's what is strengthening the existing infrastructure, that is the build capacities of the existing human resources. That means the primary care physicians, raise additional human resources if required. Develop linkage with the existing programs and the ministerial activities. I've told you that the hepatitis B and C and the HIV, they have the similar routes of the transmission. So therefore, the other programs, for example, National AIDS Program, AIDS people, they have the more chances of having B and C. So we have to integrate, we have to link it to these programs, which include AIDS control program and the immunization program, Department of the Drinking Water and the Sanitation to have the safe water, ART, as well as the OST. And they develop a web-based viral hepatitis information and the management system to maintain the registry of the persons affected with the viral hepatitis and its sequelae. So once you diagnose, we have to maintain the records that should be the web-based. And what are the components of this program? There could be the one is the preventive. I've just told you it could be the diagnosis and the treatment, and it could be the monitoring and the evaluation. So these are the components that is very essential for the success of these programs. Because what is more important, the patient who is diagnosed in front of you, very well you can treat them. But the person who is not coming forward to you and you have to make the diagnosis in that population, that is a challenge in front of us. That's why the program has to be at all levels, starting from the medical colleges, the institutes, down to the district level, sub-district level, and the primary health centers also. So the preventive awareness generation and the behavior change communication, immunization of the hepatitis B, that is very, very important. I think this is the single most very effective tool to prevent the hepatitis B. And the example is the Taiwan. And the Taiwan incidence of the hepatitis B was more than 10%, between the 10 and 15%. Once they have initiated the vaccination program at the national level, it has gone down less than 1% or so. That is a very good example. So, for example, the immunization of the hepatitis B, that is the birth dose should be given, and the subsequent immunization, high risk groups, you all know also, and the healthcare workers must. If I ask you how many you have the hepatitis B, I would say the 50% would not be having even the single dose of the hepatitis B. That is a very sad affair. So at least healthcare workers, all of us, at least 70-80% are the healthcare workers. We should have the hepatitis B immunization also. And the baby born with the hepatitis B surface antigen positive buzzer. So safety of the blood and the blood products, injection safety is very, very important. What we have demonstrated in the Punjab, the most common route of the transmission is unsafe injection practices. So unsupervised section where a quack is giving the injections and using only the single syringe, single needle to so many people for just the minor illnesses like the pain and the fever, and that is the most important. More another route you all know, shaving, getting shaving outside and other things. So what I am saying, the injection safety is very, very important, and the safe drinking water, hygiene, and sanitary toilets also. I think this is, you all know Swachh Bharat also, and they are trying to provide the Swachh water also. Diagnosis and treatment, I have told you that once you diagnose, the diagnosis should be at the point of the care test at the site of the, and then the free screening, diagnosis and treatment for the both hepatitis B and C must be made available at all levels of the healthcare in a phased manner. and the provision of the linkage of the diagnosis and the treatment. Once you diagnose, the person must be linked for the treatment within a week or so. The next day, I would say. If the gap is prolonged, then there is chances that even after making a diagnosis, the person would not get the treatment. So the linkage to the diagnosis and the treatment is very, very important. This is the network of the laboratories under the National Viral Hepatitis Control Program. If you see at the top of the pyramid, that is the center of the excellence. They have the capacity to do everything, including the genotyping and the sequencing. RT-PCR, that is the nucleic acid test, that is also available, besides other also. But if you go at the bottom, that is the primary healthcare center, there is a rapid diagnostic test is available. So if it comes out the positive, then it can move to the other level, that is district for the confirmation, and which have then access to the RT-PCR test also. That is, I'm just talking about the hepatitis C. Same is true with the hepatitis B also. Monitoring and the evaluation. Monitoring and the evaluation is very important. Once you select a patient for the treatment, or once you register the patient for the treatment, it is very important the treatment should be completed. For example, in hepatitis C, the treatment is only for the 12 weeks or maybe maximum of the 24 weeks. So the 4 weeks treatment, there is the one bottle. So every patient has to come every fourth week. So the monitoring is very, very important. If somebody does not come within 5 days of the next proposed taking of bottle or 24 weeks treatment, then there should be the alert generation that the person has not come, so that you may contact. So this is called as the monitoring and the evaluation. And they say the research also, the operational research in the same segment could be done from the Department of the Health Research. I have just told you monitoring and the evaluation framework and establishment of an online web-based system also. So the data is very, very important. Once you have the data, then you can have the results. What is the percentage of the success? That is very, very important. Training and the capacity, I have told you that we can train the people who are peripherally placed. There is primary care providers also, and we have done. I will just show you in the model that we have done in Punjab also. NVSCP, the key documents. There are at least 5 documents. One is the diagnosis and management of the viral hepatitis, and I was the chairperson of the TRG of this document. And another was the technical guidelines for the diagnosis and the management of the hepatitis B. I was the same, the TRG chairman for this also. And the 3 more, National Action Plan combating viral hepatitis in India, and the National Laboratory Guidelines for the viral hepatitis, and the National Viral Hepatitis Control Program operational guidelines. So these are the guidelines which have been made so that these programs runs effectively. And there are the management units at the level of the national, that is the joint secretary, at the level of the state viral hepatitis management unit, that is the nodal officer, and at the district level, that is the program officer, and they have to run the program also. And this is the flow chart that you can see over here, that goes from the national to the state to the district and the sub-district level also. I will not elaborate on it. So I'll just tell you in 5 minutes. I have 5 minutes. Of the program. India, I have told you, that is a low prevalence, that is the 0.6% only if you see the green. But if you see the population of 130 crore population, so it becomes a huge burden in India, that is 62 lakhs, 6.2 millions also. And that is only the third after the China and the Pakistan. So we have to treat this burden. In India also, that's why we have the National Viral Hepatitis Control Program. And Professor Tripathi has already told what are the targets for the elimination 2030. And it is an enormous task, but we can do it over here. In Punjab, we started with the 3.6% prevalence in 2.8 crore population, viremic patient 8,000. And what we have done, we first of all, we make the standard operating procedures also, and then there is this capacity building of the healthcare workers. And that we have done at the peripheral level in all district hospitals of the 22 districts of the Punjab, where we have held the workshop of the 4 hours and followed by the extension community health outcome program. Basically the telemedicine. Our PGI was the hub and the spokes were the 25 centers including 22 districts and the 3 medicals. And we used to discuss about the cases also, and we have to give some didactic lectures also, and we used to do every Tuesday between 11 and the 1 p.m. So whenever they have the difficult case, they have to discuss, or we present the good cases to them as an example also. If something happens between these two Tuesdays, the urgency, then they could contact with us through the WhatsApp group also. So we trained also district epidemiologists, pharmacists also, and we have the data management operators also. And monitoring and evaluation was done by the CHAI group, that is the Clinton Health Access Initiative. And you can see that the one session that is going on, hub and spoke, and you can see that the hub, we are sitting here, and these are all spokes. And initially we started with the 25 centers, and thereafter you can see that we have the center president, we have included sub-district hospitals also, ART centers and the OST center. And that means bring hepatitis care closer to you. That we have taken from the institutes to the district hospital, sub-district hospital, and finally that you can see the others also. So these are the paradigms that we have used also. This is, we can diagnose the cirrhosis also, and here you can see the cascade. So far 3,52,000 they were screened, 1,56,000 screening positive, refer to the MPanel lab for the viral load and treatment initiated, completed, on treatment also, deaths, failures also, and its response rate was around 92% or so. What is the lesson learned actually from this Punjab model, which has been replicated as a national viral hepatitis control program? Basically, the capacity building is very, very important at the peripheral level, and the decentralized mode of the diagnosis and management is very, very important. I will close here, and I would like to conclude. Hepatitis C virus or hepatitis B virus infection, they are real public health problem in different parts of the country. And the goal of hepatitis C elimination by 2030 using primary care providers and remote treatment monitoring. An NVSCP was launched to combat hepatitis and achieve countrywide elimination of hepatitis C by 2030. And the model utilizes unique combination of the remote patient monitoring and telemonitoring using telehealth technology in improving patient outcome, decentralized care of the patient with hepatitis C or hepatitis B virus infection using generic oral drugs, and for hepatitis B we also have the oral drug, is safe, effective regardless of the viral load also in this patient. I acknowledge for this Punjab data, the government of the Punjab, particularly Dr. Gardeep Singh, who is a program officer, and my colleague Dr. Madhumita Prem Kumar, who is the associate professor in the Department of the Hepatology PGI. Thank you so much.